So hello students, today I am going to teach you about the X-rays. So what are the questions which are coming in the exam, and what are the questions you will be asked about the X-rays. So I'll be here to teach you. So first of all, you have to read the X-ray. So I'll be going to teach about firstly of the X-ray of forearm. So how will you read the X-ray? So you can start from like this. So this is the X-ray of skeletally mature forearm taken in AP and lateral view, showing the bone like radius, ulna, distal part of humerus, carpals and metacarpals. Also there is some support which is called as a Kramer wire support. So in this X-ray, next question will be asked about what is the problem. So the problem is there's one bone fractured. That bone is a ulna, the proximal ulna fracture, and this radius proximally is dislocated. The proximal radius dislocated है and proximal ulna का fracture है. So इस fracture को क्या बोलेंगे? That is called as a Monteggia fracture dislocation. So what is Monteggia fracture dislocation? Proximal ulna fracture and proximal radius dislocation. Okay. So what is the treatment in this patient? Like open reduction and internal fixation with plate and reduction of the radial head. So that's it. So next, the another one patient, the same you have to start with the how to read the X-ray. Then what is the problem in this? Again you can see this the ulna, and this one is radius. This is the distal part of humerus, carpals and metacarpals. This one is the ladder-like structure is a Kramer wire. So in this, the proximal 1/3 of ulna fracture and proximal radius, it means radial head is dislocated in lateral view, and this one is AP view. So what is the treatment? Open reduction, internal fixation with plate and reduction of radial head. Now the next patient is again you can see there is the distal part of humerus, that this one is ulna and this one is radius, radial head. Radial head is dislocated, proximal 1/3 of ulna fracture, and the treatment is the same. Now this one is the opposite of Monteggia fracture. Monteggia, this one is Monteggia and this one is a Galeazzi fracture. Why it is Galeazzi fracture? In Galeazzi fracture dislocation, the distal 1/3 of radius fracture and DRUJ, distal radioulnar joint dislocation. This one is dislocated. This ulna is distally migrated. So in this, what will you do? The open reduction, internal fixation with plating, and in this reduction of distal radioulnar joint with K wire. So this one is Galeazzi and this one is Monteggia fracture. Now third one is the wrist joint. In this one is the ulna, this one is the radius. So here it is the ulnar styloid fracture, ulnar styloid process fracture, and this one is distal end of radius fracture. Okay, these all are carpals and these all are metacarpals. So in this, what we are going to do? Closed reduction and casting. So firstly the patient will come to you. You can do closed reduction and the slab. If the fracture is reduced, then after 7 days you can do the casting. So closed reduction, if the fracture is not reduced, after the closed reduction you can do the closed reduction and external fixator, or you can do the polar plating. Okay. So now the next X-ray is, so this is the skeletally mature X-ray. So how it is, why it is a skeletally mature X-ray? You can see the physis. So these all physis is not fused. So this is the skeletally immature patient of forearm taken AP and lateral view with adequate exposure with the Kramer wire support and showing distal part of humerus, radius, ulna and carpals and metacarpals. In this X-ray you can see the distal 1/3 of both bone forearm fracture. Distal 1/3 of both bone forearm fracture. So what we are going to do in this case, you can do the firstly immobilize with the Kramer wire. Then after the process, after the pre-op preparation, you can do a close reduction with slab fixation, or otherwise you can do close reduction with internal fixation with K-wire or tense nail. So these are options. The second one is the another one. The patient also have a immature bone, the distal one, distal part of humerus, proximal part of ulna and radius. So in this distal part of humerus is fractured. That is called as a supracondylar humeral fracture. So this is the supracondylar humeral fracture in this case. This supracondylar fracture is proximally migrated, medially tilt and rotational. So these all are component of the supracondylar fractures. So what you are going to do in this case? In this case you can do the close reduction and cast application. If it is not reduced, then close reduction and internal fixation with K-wire or after the slab. Okay. So the next patient is this is a mature, skeletally mature X-ray. This is the radius, ulna, distal 1/3 of ulna is fractured. DR regional joint is normal. The carpals and metacarpals. But in this case, this series, the second metacarpal is fractured. So what you are going to do in this case? Also you apply the slab. Also, examiner can ask about the what are the carpals. So you can start from the radial side to the ulnar side. So this is the scaphoid, this is the lunate. So you can apply like this. So first one is the scaphoid, lunate, triquetrum, pisiform. Now second row, this trapezium, trapezoid, trapezium and trapezoid. Both are in the same way, trapezium, trapezoid, capitated and hammered. Okay. So now come to the leg fracture. So in this you can tell like this. So this is the skeletal mature X-ray of leg taken in AP and lateral view with adequate exposure. Support with the Kramer wire showing the tibia, fibula, talus, calcaneum and part of metatarsals and tarsals. Okay. So what are the problem in this case? In this case you can see this one is the fracture. So this is the fracture of proximal 1/3 of tibia and proximal 1/3 of fibula fracture. So what is the problem? So how you are going to treat in this patient? So firstly the patient come to us in the emergency department. You can apply this Kramer wire or slab and send the patient for the X-ray, and after the X-ray you can see this. So immediately you can put the patient for the OT, and you can apply the nailing, intramedullary nailing, or you can also apply the if there is a wound present, if there is open wound present or compound injury, you can apply the fixator as well. Okay. Then one of the most common complication of this closed tibia fracture is it is a compartment syndrome. And next one is there is some neurovascular structures like common peroneal nerve wind around this fibula. So also there is a common peroneal nerve CPN injury, and it will lead to the foot drop. The second one is the second X-ray is the distal 1/3 of tibia fracture, and also part of the fibula, proximal or neck of fibula fracture here. Here the same complication patient will have the CPN. The CPN injury will lead to the foot drop. So what treatment you will apply in this case? You can also put the intramedullary nailing. So next, so now we are going to discuss about the hip. So in the hip you can also tell like this. So this is the X-ray of skeletally mature patient taken in AP view with no rotational with adequate exposure. showing the pelvic bone, ilium, ischium and pubis. Okay, ilium, ischium and pubis. Okay, then the head of femur, neck of femur, proximal part of the femur as well, and some lower part of the vertebra and the sacrum and coccyx as well. So in this X-ray, what is the problem? So in this X-ray, left side is the normal, okay, but the right side is this abnormality. It means this abnormality is like at the level of intertrochanter. This is the intertrochanteric part, this is the lesser trochanter, this is the greater trochanter. So this, in both trochanter, you can call it as a intertrochanteric area. So in this intertrochanteric area, there is some fracture, some kind of fracture. So this fracture is called as a intertrochanteric fracture. So what you are going to do in this case, you can apply the proximal femoral nailing or DHS. The second X-ray is the same patient. So the same like pelvic patient. So in this X-ray, right side, right hip is normal. This is the greater trochanter, lesser trochanter, neck of femur, head of femur, and this part, head of femur, but the neck of the femur is fractured. So this fracture, you can also read about the neck of femur classifications. So in this X-ray, what you are going to, how you are going to treat in this patient, you can also see the age of the patient. If the age is, like if the patient is young, you can do the fixation like CCS fixation, CCS screw fixation. If the patient is older and patient is not able to like do all the work, you can do the hemiarthroplasty or bipolar hemiarthroplasty. You can replace the head of femur part and do the bipolar hemiarthroplasty. If the patient is around 50 or so this is the neck of femur fracture. So in this case, if the patient is young, like 30-40 year of age, and the primarily you can do the CCS fixation, 3 screw from like this. If the CCS screw is failed or the acetabulum is arthritic, then you can do the total hip arthroplasty or THR. Now the next one is this patient. This is the pelvic patient. You can see this, the normal head is inside the acetabulum. This is the acetabulum area, and this is the head of femur, this is the neck and GT and LT, and this one is the acetabulum. This acetabulum is empty. You can see there is no head of femur here. So it means the head of femur is dislocated. This is the posterior dislocation. So what are the other type of dislocation, like anterior dislocation, center dislocation, like the obturator foramen. This is the obturator foramen dislocation. So these are the other type of dislocation. So in this case, immediately you can reduce the dislocation, reduction of the dislocation, reduction of the head of the femur, and apply the splintage. Now this is the next patient. So again, this is the skeletally mature pelvic bone. Now this one is the head of, this one is the head, this one the GT, LT, neck of femur. This is the neck of femur. So here is the intertrochanteric. This one is the intertrochanteric line. So intertrochanteric fracture. So in this case, what you are going to do this, the proximal femoral nailing, or you can do the DHS, dynamic hip screw system. So this is the next humerus patient. So again, you can read like this. This is the skeletally mature arm taken in AP and lateral view, showing the part of chest, clavicle, and part of scapula, proximal part of humerus, part of distal humerus, and proximal part of radius annula. You can see in this case there is this humeral distal 1/3 of humerus is fractured. So, but which one is the most common complication in this fracture? So in this fracture, the radial nerve is going like from posterior, going lateral and then anteriorly. So the radial nerve is trapped inside this fracture, and this will lead to radial nerve palsy. Okay, this fracture, the spiral fracture, call it as a Holstein-Lewis-like fracture. Now this one is unique patient. In this X-ray you can see your tibia, distal femur, fibula, and this structure. So this is the structure. This is a like a rod-like structure. It's called as a external fixator. So this is the rod, and this will tube-like structure rod. This one is a sand screw. This one is sand screw going inside the tibia, and this one is the clamps. So this is for the open wound. Like if the patient have an open wound or compound wound, that in that case that you cannot apply the nail or plate, you can apply the external fixator, so that the wound condition is like healed over the period of time, and after the wound is healed, you can remove this external fixator, and this then secondary management will be done after that. So in this case, again you can see the most common question asked, like what are the complications of the fibula fracture at the neck of fibula, that common peroneal nerve injury. So these small sinuses, like it means that previously somebody has applied the plate, and these impressions like previously the screw of the plate. So that's it. Now the next patient is like knee patient. So this is the X-ray of skeletal mature patient taken of the knee, AP and lateral view on standing. So in this case you can see the space. So in standing view you can see the space. This is the lateral compartment, medial compartment, but in this case you can see the medial compartment joint space is reduced. See here what is the joint space? This is almost 2 to 3 mm, but in this case joint space is reduced. This is the small osteophytes. So you can see this is the osteoarthritis patient of the right knee. So what you are going to do in this case, you can start the NSAIDs and calcium and vitamins, so that the bone is strengthened. So again you can also ask for the quadriceps strengthening exercise. You can do some injection therapy like PRP therapy. If this grading is like a grade 4 or the knee deformity, you can also go for the total knee replacement. So again you can see so many X-rays of the knee joint. So in this case you can directly see these are the middle compartment and lateral compartment of the knee joint. You can see the right knee, these are the big osteophytes. Joint space is reduced. It means the right knee is osteoarthritis, but in left there is only mildly osteoarthritis. But the second X-ray is, you can see the joint space is normal. There is no abnormality in this case. It means that this X-ray is normal. Now third one, you can also see some kind of loose body inside the middle compartment, but the joint space is normal. So it may be some due to the meniscus hypertrophy or some kind of loose body inside the knee joint. So the next one is this one is the femur. This one is the femur. This is the head, greater GT, LT, and this one is the diaphysis of the femur. You can see some implant is inside this bone. It means the implant is like very old. Implant is fractured, implant is failed. The bone is united. The huge callus formation around the fracture site. Now this is the X-ray of the foot taken in AP and oblique view. You can see the calcaneum. This one is calcaneum. This one is talus. In front of talus there is a navicular bone and 3 cuneiforms like medial, intermediate and lateral cuneiform. In front of calcaneum there is a cuboid, and these are metatarsals. These are all 7 tarsals, metatarsals and phalanx. Now you can see the small fracture over the proximal phalanx of the great toe. It means like some avulsion of the medial collateral ligaments. So, and also there is a fracture of the second metatarsal base. So these are some ligaments like called as a Lisfranc ligament, which is attached from the middle cuneiform and first metatarsal to the second metatarsal. So this might be case of Lisfranc injury or this proximal phalanx fractures. So that's all about the X-rays. So hope you guys understand all the X-rays, and all the best for your exam. Thank you.